Good afternoon, and welcome to our webinar on using the Agency for Healthcare Research and Quality's Medical Office Survey on Patient Safety Culture. My name is Joanne Sora. I'm the WESTAT Project Director for the AHRQ Surveys on Patient Safety Culture, and I'll be the moderator for today's webinar. At this time, all participants are on a listen-only mode. A brief question and answer session will follow. If anyone is listening through speakers on their computer and you need assistance, please select the Help button at the top right-hand corner of your screen. If anyone using the phone line should require operator assistance, please press *0 on your telephone keypad. As a reminder, this conference is being recorded. Next slide. Currently, there are patient safety culture surveys for 3 healthcare settings: hospitals, medical offices, and nursing homes. AHRQ released the hospital survey in 2004, the nursing home survey in 2008, and the medical office survey in 2009. The completed surveys and toolkit materials can be found on the AHRQ website. AHRQ is currently funding the development of a patient safety culture survey for use in retail pharmacies. Today's webinar will focus on the medical office survey, also referred to throughout today's presentations as the medical office SOPS. Next slide. In addition to me as the moderator, we're really pleased today to welcome 3 outstanding speakers. Joining us from Cleveland, Ohio is Dr. John Hickner, Chairman of Family Medicine at Cleveland Clinic. Joining us from Portland, Oregon is Dr. L.J. Fagnan, Associate Professor of Family Medicine at Oregon Health and Science University and Director of the Oregon Rural Practice-Based Research Network, ORPRN. And here in Rockville, Maryland is Dr. Naomi Dyer, Senior Study Director at WESTAT. Next slide. The agenda for the webinar is outlined on slide 4. We'll start with Dr. John Hickner giving an overview of the development of the medical office SOPS. Then Dr. L.J. Fagnan will present information about a large-scale data collection conducted with the Practice-Based Research Networks, or PBRNs, along with valuable lessons learned. Next, we'll hear from Dr. Naomi Dyer, who will present preliminary comparative results on the survey. She will also share results on how patient safety culture perceptions differ between physicians and medical office staff and by medical office characteristics. Finally, I will share information about an upcoming comparative database for the survey, and then we will end with a brief question and answer session. Next slide. Before we get started, I have a few housekeeping items. Although we will only answer questions at the end of the webinar, you may type in and submit a question online at any time throughout the presentations, and it will go into a queue. You will see a box at the bottom left of your screen with the heading, Ask a Question. Simply type your question in the box and select Submit. Next slide. If you cannot see the slides on your screen without scrolling, you can adjust your screen resolution to 1024 by 768 or higher, which will fix this problem for you. Each operating system is different, but you can typically do this by right-clicking on your desktop and selecting Properties and then Settings. Next slide. To access the slides at any time, select the Event Materials tab at the bottom of your screen. Next. And finally, if you need help at any time during the webcast, just select Help on the upper right portion of your screen. And if you're using a telephone line to hear the audio, you can dial *0. Next. If you're unable to hear the webinar through your computer speakers, you can join us by phone at any time by dialing 1-877-407-4035 and entering the passcode 368357#. If your computer freezes during the presentations and the slides are not advancing, you can try hitting the F5 button on your keyboard to refresh your screen. However, keep in mind that you may just be experiencing a lag or delay in the advancement of the slides due to your internet connection speed. You can also try logging out and logging back into the webinar. Now, on with our program. Our first speaker will be Dr. John Hickner, Chairman of Family Medicine at Cleveland Clinic, giving an overview of the development of the medical office SOPS. Next slide. John?
Good afternoon. This is John Hickner. Next slide, please. The objective of my presentation will be to describe for you the development of the medical office survey on patient safety and to discuss briefly the pilot testing of the survey that we did here in the United States. Next slide. As background, recall that the hospital survey on patient safety was released in November of 2004. Before long, people realized that there was great need to have a survey for office practice as well, and the same team at Westat began development then of the Medical Office Survey, which was released in January of 2009. Next slide. We went through the same development steps as occurred for the hospital survey on patient safety with a very scientific approach. First, reviewing the literature and existing surveys, conducting background interviews with medical office physicians and staff, and I wanted to interject that the term patient safety was really quite foreign to many people that work in medical offices. They tended to think of the fire extinguisher and tripping on the sidewalk, and of course we mean a lot more than that. We then identified key areas of safety culture in the medical office setting, developed the survey items, conducted cognitive testing of those items, and obtained input from over 24 researchers and stakeholders so that we had the right content and formatting. And then finally pilot tested the survey, analyzed the data, and then made final adjustments to the survey. Next slide. Now, the goals of this survey are typical for safety culture surveys. First of all, we hope to raise staff awareness about patient safety by those who complete the survey, because one learns a great deal about patient safety as you complete the survey by the nature of the questions. We also want, of course, to assess the current state of patient safety culture in office settings to provide a baseline for future measurement, and use these surveys then for internal patient safety quality improvement in primary care and other office practices. We want to evaluate the impact of patient safety and quality improvement initiatives using this as one of the evaluation tools, and naturally to track improvements in patient safety culture over time. Next slide. The hospital SOPS has the following 12 dimensions, which are listed in front of you. And I'm not going to read each one of those, but I will pause for a minute to have you look these over. And when we move on to the next slide, you'll notice that some of these dimensions are carried forward, but some new dimensions emerge for the Office Culture Survey. Next slide, please. Now, we're seeing now the first 6 dimensions of the medical office survey on patient safety culture. And first are dimensions that look different from the hospital survey. You see patient safety and quality issues listed under number 1, which are more specific to medical office practice. Information exchange with other settings is always a difficulty in outpatient practice, and an opportunity for error and the need for safe procedures. Office processes and standardization, of course. Work pressure and pace is a big issue in primary care offices especially. Patient tracking and follow-up, because patients are usually not in our offices, and staff training issues. Next slide. These are the other 6 dimensions of the medical office SOPS, which are quite similar to the hospital survey, although the questions may be slightly different. I'll pause briefly for you to read these. Next slide. We then tested the survey. It was a large pilot test. Hard to call a pilot when you have 182 medical offices, 4,174 doctors, other healthcare providers, and staff respondents. So it was a very big pilot. And listed below are some of the organizations that we worked with in doing the pilot testing. Next slide. These are some characteristics of the offices in which we test the survey. 63% were single specialty, 37% multi-specialty. And you can read the breakdown of the various types of practices and size of office practices. You can see that most of these practices were a bit larger. Not too many really small office practices. Most of these were somewhat larger office practices. Next slide. "69% of these practices had only one location, but some had several locations, obviously, and most were owned by a hospital or healthcare system, which is fairly typical now in the United States. 25%, however, were owned by physicians or other groups of physician providers. 14% were university and academic. Use of electronic tools refers to implementation, for the most part, of electronic health records. And this gives a breakdown of how many were fully implemented. But as you can see, most of these practices did not have full electronic medical records." Next slide. The test, the survey, was administered to all the doctors and staff in these offices, and most used paper forms, only 29% web. Next slide. The response rate was phenomenal. Terrific response rate. You can see those listed as 70 and 78% versus 65% for web. Average responses per office, 23. Average response rate, 74%. So a great response rate. Next slide. And these are the people who responded, broken down in this pie chart. You can see the job descriptions. So we have a pretty good representation of not only the physicians and other providers, but also office and support staff, both clerical and clinical. Next slide. And the data was analyzed, of course, mainly looking at the psychometrics and dropping poor performing test items. And then the survey was completed and released in 2009 with a Spanish version to be released soon. Note that the Cronbach Alpha reliability testing was very good. So basically that means that the dimensions that we defined really hang together well. Next slide.
Thank you, John. Now let's transition to Dr. L.J. Fagnan, who will present information about a large-scale data collection conducted with the Practice-Based Research Networks, or PBRNs, along with valuable lessons that he learned. L.J.?
Yes, thank you, Joanne. This is L.J. Fagnan in Portland, Oregon, and I'm going to build on what Dr. Hickner was talking about with the 182 pilot sites, and we're going to look at this from the perspective of the individual practices and how we used our practice-based research networks to engage these practices, looking at perceptions of processes, values, and potential use. Next slide. So we created a consortium of practice-based research networks out of the 110 primary care practice-based research networks around the nation. ORPREN convened 11 networks to survey 311 primary care offices with the medical office SOPS. We sent out invitation to the PBRN director saying we want a mix of urban and rural clinics, specialty, health information technology enabled, and ownership variation. And we actually developed a website for the study, and that's still operational. Next slide. So these are a list of the networks, the 11 networks around the country. Most are state-specific, some are regional, and one is national. But we've covered quite a bit of the United States with these 311 practices. Next slide. So the goal was to have each network recruit 25 or more practices. The practice-based research networks built on their own experience and expertise in terms of recruiting practices. What ORPREN did was provided letters of invitation, a template for letters of invitation, information sheets for the offices, and importantly, information for the point of contact at the office with duties that were quite specific. Next slide. And so the sampling, we wanted to get a wide range of primary care offices. We looked at single specialty, although predominantly these were family medicine practices. We had also pediatrics and internal medicine. We had some multi-specialty, mostly single specialty. We had a mix of small practices with 2 to 3 clinicians. Large practices were defined as 4 clinicians or more. And then we also looked at whether or not the practices were health information technology enabled, and there are 5 items here, and we considered them enabled if they had 3 of the 5 items that were listed there. Next slide. And so then we actually tried to find out how this was working and how these networks actually did engage the practices. Practices are pretty busy, and we wanted to figure out what they did. And so the vast majority of networks actually traveled to the offices and delivered the surveys. They followed up with phone calls, but face-to-face meetings were the main method of connecting with these practices. Next slide. And so we asked, we were asking the PBRN coordinators, not the practices, about what worked best for you to distribute these and collect the surveys in your office. And by and large, there's no substitute for face-to-face meetings with the point of contact in the offices. Many of the networks did this around the lunch hour. Food seems to be a great convener, and actually worked with the staff to complete it. We got the majority of the staff in these offices at that time, and the point of contact then followed up afterwards, and the PBRN followed up with the point of contact using emails and phone calls. But again, the emphasis here is showing up in person at the office. Next slide. So we did a survey of the point of contacts in these offices, and this was an AHRQ task order with a defined deadline, and so we had to do this fairly rapidly after we completed the study, and so these were the early response rates, and we were trying to look at what were the barriers encountered in completing a survey, what could we do to improve survey administration, and what did the offices think about the value and potential uses of the survey. And we had variable response rate with this group of early responders, and 2/3 of the respondents were office managers. Next slide. Looking at the enthusiasm among clinicians and staff, there was some degree of enthusiasm for 2/3 of the folks, and this was pretty. We felt good about this because practices are really busy. They have a lot going on, and to get 2/3 of the folks saying, you know, we're somewhat enthusiastic or very enthusiastic about this was very positive. Next slide, please. Some of the positive comments were that I was hearing back that they could not wait to get the results back from the survey. The staff were very enthusiastic when starting the survey, realizing it asked great questions about job satisfaction. Next. On the other side of the scale, staff were just really not responsive to filling out surveys. They kind of wondered why they were being surveyed and suspicious of what was going to be done about it. Surveys the results need to be taken into account on the fact that this is a snapshot, and you're just getting the feelings of the person that day. If they're having a bad day, it might reflect on the survey. And then competing priorities play a role. One practice reported that, look, we're implementing an EHR. This is not good timing for us, and things are kind of stressful. Next slide. Do you feel the survey items addressed all areas of patient safety? Most folks felt it was fairly comprehensive. A couple of comments that are worth noting is that the medication error questions were too nonspecific to really provide some quality improvement activities. They wanted more specifics on care coordination. In the qualitative comments, a gap in this survey was really around the areas of access. Access to parking, lighting, access for handicapped patients, and extended hours for clinics. This came across in some of the comments. Next slide. So Westat created reports for each of these 311 offices, and these reports went to each PBRNs for their group of offices, 42-page report, and the networks then decide how they were going to distribute these reports. What we did is we took PDFs and emailed them to the lead clinician and the point of contact at the office. And many of us said, yeah, we're going to go visit or have visited the office with the results. Next slide. And so the practices, this is early on, had held meetings. They were planning to do that. About a quarter were going to just provide written reports only. And some said, we're not going to do anything with it. Next slide. And so again, this is from the point of contact perspective, as your office benefited from participating in the survey. And they said obtaining internal data in a safe environment was very beneficial and allowed for honest answers. These are clinician comments here. Interesting to note, areas of concern from the staff perspective has opened a dialogue on many issues. One office staff point of contact says, staff that will discuss the reports, the office manager and physician didn't seem interested in exploring the report. And another physician said, I have monthly staff meetings. I'm going to break these down into sections and discuss them at each staff meeting. Next slide. What feedback have you heard from the medical offices in response to the reports? They thought that the results were interesting. One office manager felt like it was too lengthy and complex. A comment, this is from the PBRN perspective, I got the feeling that most clinics didn't share the results with their staff, and even when they offered to try to be helpful. There was some confusion around negatively worded questions. Next slide. We asked for suggestions about using the report in the medical office, that we need to explain the results carefully, particularly around the reverse coding items, double negatives. Again, no substitute for going to the practice and talking to clinicians and staff. The practices felt that the PBRN should provide education and support. Otherwise, many offices don't take the time to review the results or share them. Next slide. And so this is my last slide here. I asked about any other comments, and here's what I wrote. It says the project was much more fun than I anticipated. These are, again, from what the PBRN has heard from their practices. The results were reviewed with the clinics were well received by staff and administration. The range of responses I heard when implementing the survey was great. Some examples are, I'm so glad you asked. Nobody ever asked the front desk for their opinion before. Another young woman came with her survey in her sealed envelope tightly clutched to her chest. She asked, are you absolutely sure my manager will never see my survey? They won't know it's me, right? I also heard, this is the dumbest thing I've ever done. That person was very interested in the results once it became apparent that things weren't working as well as she had thought they were. And next turns it over to Naomi, I think. Okay.
Thank you, LJ. Now let's transition to Dr. Naomi Dyer, who will present preliminary comparative results on the survey. She will also share results on how patient safety culture perceptions differ between physicians and medical office staff and by medical office characteristics. Naomi?
Thank you, Joanne. So this is Naomi, and now that we've had a nice background of the development and pilot of the survey as well as the PBRN effort, I'm going to be focusing on two objectives. Next slide. First, I'm going to present some of the comparative results from the combined pilot PBRN database. The full report can be found online at the link shown on your screen. Second, I'm going to present some results that examine the relationships between the medical office SOPS scores with staff positions and medical office characteristics. Next slide. The combined pilot PBRN database consists of 470 medical offices with 10,567 respondents. The overall response rate, which is simply the total number of staff responding divided by the total number of staff asked to complete the survey, was 73%. The average response rate across the 470 medical offices was 78%, with about 22 respondents per medical office. Next slide. This figure shows 6 of the 12 patient safety composites ordered from the highest percent positive to the lowest. As you can see here, the top average percent positive response was for teamwork with 82%, followed by patient care tracking and follow-up at 77%, and organizational learning and overall perceptions of patient safety and quality at 74%. Next slide. Overall, the three lowest composites were work pressure and pace, which only had 46% positive responses, followed by information exchange with other settings at 54%, and office processes and standardizations at 59% positive. So what we see is some variability across the composites, ranging from an average of 46% positive to 82% positive. Next slide. The survey also had an item asking the respondents to provide an overall rating on patient safety. As can be seen here, an average of 64% of respondents rated their medical office as either excellent or very good. And as noted, these are just a preview of the results, and the full results, including breakouts by staff physician, can be found on the AHRQ website. Next slide. Okay, so switching gears a little bit, we have this really large data set, and we wanted to explore the relationships between the patient safety culture scores and staff physicians and medical office characteristics. Next slide. To do this, we used the 12 patient safety composite scores, but we also created an overall average composite score, which is simply the average across the 12 composites, or a summary kind of patient safety culture score. We also created the average rating on quality. One of the items on the survey asked respondents to rate their medical offices on the extent to which their office was patient-centered, effective, timely, efficient, and equitable, and we took those items and averaged them across to create this average rating on quality. And then we looked at the overall rating on patient safety. All the measures were calculated at the medical office level, and we looked at the percent positive response. Next slide. So we had 5 questions we wanted to explore. Are there differences in patient safety culture scores by staff position, by medical office characteristics such as office size, ownership, specialty, and the degree of health information technology implementation? Next slide. So the first question was, are there differences by staff position? And we predicted that of all the staff positions, the positions would be the most positive about patient safety culture in their medical offices than the other staff. Next slide. There were 7 staff positions listed on the survey, and the respondents mostly fell into the administrative or clerical, as you can see here, with 28%. And these staff are like the front desk, receptionists, medical records personnel. This was followed by other clinical, and these are your technicians and therapists. Then your physicians at about 20% of the respondents. And then you see your RNs, LVNs, LPNs, management, physicians' assistants, etc. Make up the rest of the sample. Next slide. So to look at this, we calculated the average percent positive score by staff position at the medical office level and conducted one-way analysis of variance to see if there were differences across staff positions. Next slide. When we looked at all 7 staff positions, we found out that there were some staff positions that were really similar to each other. And basically we found that management and physicians were very similar on all of these 15 measures that we looked at. And the other staff positions were also very similar. So instead of trying to relay all the different relationships that existed, we collapsed it down into management and physicians versus all other. Next slide. What we found were that management and physicians were more positive than the other staff on 11 of the 15 measures. We see an average difference of 9 percentage points, and it ranged from 4 percentage points to 19 percentage points. So as we go through these analyses, what I'll show you is this table that presents the results for the 3 summary scores, the average SOPS composite score, the average rating on quality, and the overall rating on patient safety. And then I'll highlight for you any of the major differences. So on this table you see here, we see for the average composite score, management and physicians were at 70% positive, while all others were at 66% positive, for a 4 percentage point difference. For average rating on quality, we see 11 percentage point difference, and for overall rating on patient safety, we see a 5 percentage point difference. Next slide. The largest difference we found where management and physicians were more positive than all other staff was for communication openness, which is on the left-hand side of this figure, where management and physicians were 79% positive, while all other staff were only 60% positive. We see a similar pattern for staff training, where management and physicians were 82% versus all other staff at only 68% positive, for a difference of 14 percentage points. And for communication about error, we see a 9 percentage point difference between the two staff positions. Next slide. So while they were more positive on 11 of the 15 measures, they were less positive than all other staff on 3 of the 15 measures. And we see these 3 measures here: information exchange with other settings. The management and physicians were at 45% positive, while all other staff were at 58% positive, for a 13 percentage point difference. Patient care tracking and follow-up, we see a 12 percentage point difference. Again, all other staff are more positive on this measure. And the same thing for patient safety and quality issues, for a 5 percentage point difference. Now, with all these numbers, if you've done the math, I said that they were more positive on 11 and less positive on 3 of the 15. So there's still one measure out there where they weren't significantly different from each other, and that measure was the office processes and standardization. Next slide. So our second analysis question was, are there differences in these scores by medical office size? And based on our experience with the hospital survey on patient safety culture, we found that smaller hospitals tended to have more positive scores. So therefore, we predicted that smaller medical offices would have more positive patient safety culture scores here. Next slide. To examine this question, we looked at the correlations between medical office size and percent positive patient safety culture scores, where size was defined as the total number of providers and staff. And we see the range that went from 5, which is because that's how many you need to have at least 5 respondents to be included in the database, to 100. Next slide. And so when categorizing these medical offices into small, medium, and large, we see that over 50% fell into the medium office size, which is between 11 and 30 providers and staff, with 31% being large offices, or 31 or more providers and staff, and 19% were small medical offices. Next slide. We found that smaller medical offices did have slightly more positive patient safety culture scores than the larger offices on all 15 measures. We see moderate correlations with the average correlation of 0.27, ranging from 0.14 to 0.41. And so looking at the table, what we see for row 1, the average composite score, we see a correlation of 0.34, which is moderate. And what that translates to in percent positive is small offices on that measure were 74% positive, while medium offices were 67% positive, and the large offices fell down to 62% positive. Our strongest relationship is actually on this table. It's with average rating on quality. And what we see is a 0.41 correlation, which translates into the small offices being 77% positive and the large offices only being 58% positive. So that's like a 19 percentage point difference. Next slide. Our third analysis looked at the differences in patient safety culture scores by medical office ownership, where we predicted that physician provider-owned offices would be more positive than other ownership types. Next slide. Looking at the database, we see that most of the medical offices were hospital and health system owned at 51%, followed by provider and or physician owned and university or medical school owned. Next slide. So we found that physician provider-owned offices were more positive than hospital health system owned offices on 10 of the 15 measures. So we look at this table, and this table shows all 3 different types of ownership. Let's walk through it. For the providers and physicians, we see that on all 3 measures, they're about 70%. And when you look at the university academic-owned and hospital health system, they're in the 60s. And they're very similar to each other. And we actually found that university, academic, and hospital health systems were similar on almost every single measure that we looked at. Now, the largest difference that we found for the provider, physician, and hospital health system owned was for work pressure and pace, for an 11 percentage point difference, where again the provider's positions were higher than the hospital health system owned. Next slide. This slide shows the differences between the physician provider and university academic offices, where they were different and more positive on 7 of the 15 measures. The 2 largest differences, not surprisingly, we see work pressure and pace appear here again, because you see here provider and physicians are at 54% positive, and university academic and hospital health system are both at 43% positive. The next one, patient care tracking and follow-up, is the only time we see any difference between the university academic-owned offices and hospital health. So not only are there differences between the physician and provider-owned at 81%, but the hospital health system and university are also significantly different from each other. Next slide. All right, so then we looked at specialty. And the question was, is there a difference in patient safety culture scores between single and multi-specialty offices? We predicted that single specialty offices would be more positive than the multi-specialty offices. Next slide. Looking at the database, we see that 58% of the medical offices were single specialty offices, but of the multi-specialty offices, most were multi-specialty with primary care only. So to look at this analysis, we performed partial correlations. We did partial correlations so we could control for office size between specialty and patient safety culture scores. Next slide. We found that single specialty offices tended to have slightly higher SOPS scores on 6 of the 15 measures. Our average correlation was 0.13, which was actually kind of on the low range, ranging from 0.10 to 0.18. So looking at this table here, we see for the average SOPS composite score, the correlation was 0.12. But translating that into average percent positive, we see about a 4 percentage point difference, where single specialty are higher at 68% and multi-specialty are lower at 64%. We see a similar small relationship with average rating on quality, and when we get to overall rating on patient safety, it's not significant. Next slide. For specialty, though, we looked at the largest difference, and that was for owner, managing partner, and leadership support for patient safety, and we see a 6 percentage point difference, where, again, your single specialty is more positive on this than your multi-specialty. Next slide. So our final analysis was to see if there was a relationship between HIT implementation and SOPS scores. And we predicted that offices with greater HIT implementation would have more positive patient safety culture scores than those with less HIT implementation. Next slide. Again, we performed partial correlations so we could control for office size between HIT implementation and the medical office SOPS scores, where we assessed degree of HIT implementation as 1 equals not implemented and no plans to in the next 12 months, all the way to 4 at fully implemented. Next slide. So there were 5 HIT tools that we looked at. Electronic appointment scheduling there on the first row, 81% of the medical offices were fully implemented on this tool, while only 36% of the medical offices were fully implemented on electronic ordering of tests, imaging, and procedures. And then going down to that last row, we see 50% were fully implemented on electronic medical records. Next slide. And what we found actually was that there wasn't a lot of relationship with these 5 tools, except for implementation of electronic medical records. So this is showing the relationship for electronic medical record implementation, where they were slightly higher on 11 of the 15 measures. Again, we see a low to moderate average correlation of 0.15, ranging from 0.10 to 0.27. And translating that into percent positive, we look at the average SOPS composite score. We see fully implemented offices were at 67% positive, and not fully implemented were just at 66% positive. So not a huge difference there when we dichotomize those fully implemented to not fully implemented. And we see average rating on quality was not significant, and overall rating on patient safety had about a 3 percentage point difference between the fully implemented and not fully implemented. Next slide. Again, looking at the strongest relationship, or the largest difference, was for patient safety and quality issues, where the fully implemented offices were at 63% positive, and the not fully implemented were slightly lower, 5 percentage points lower, at 58% positive. Next slide. So that was a lot to go over. So just our conclusions, I'm just going to talk about these 5 analyses we discussed. And let's recap. For a staff physician, we saw that overall, management and physicians had more positive patient safety culture scores than other staff, except on those 3 where they were less positive. Smaller medical offices had slightly more positive patient safety culture scores than larger ones. Physician provider-owned offices had more positive patient safety culture scores than hospital health system-owned and university academic offices. Next slide. And for a specialty, we found that single specialty medical offices were slightly more positive than the multi-specialty offices. And for HIT implementation, overall, it was not strongly related to patient safety culture scores, though offices with greater EMR implementation had slightly higher patient safety culture scores. Next slide. So if you have any questions, these are the 2 email addresses you can write to, Databases on Safety Culture and Safety Culture Surveys, and we'd be happy to answer them. Thank you very much, and back to you, Joanne.
Thanks, Naomi. There's just one more slide before we go to the question and answer session, and this is about the upcoming comparative database for the Medical Office Survey. As many hospitals and health systems know, the hospital survey has had a comparative database, and an annual report has been produced since 2007, and we will be establishing a comparative database on this survey. The database will serve as a central repository for any medical office or system that has administered the survey and is willing to voluntarily submit their data. And this will really be a great resource for comparing results with other medical offices. Right now, we've simply presented comparative results on 407 medical offices, but once we receive data from the larger nation in terms of those that have administered the survey, we will hope to expect to see a much larger database. And the participating medical offices will receive a free medical office survey feedback report that will compare their results to the latest benchmarks. And an overall comparative report similar to the hospital report will be produced and available on the AHRQ website in 2012. The data submission will be open September 15th through October 15th, so I encourage all of those hospitals, health systems, medical offices that are interested in administering the survey to do so before September and then submit the data. And that way we can have a more robust database and better benchmarks. So for more information, the AHRQ website does now have submission instructions, and you can go to the site to see just what you need to do to submit to that database. Next slide. So now we'll begin the question and answer session. We encourage you to submit your questions at this time. We're only accepting questions that are submitted online. So you'll see a box at the bottom left of your screen with the heading Ask a Question. And all you need to do is type your question in the box and select Submit. So please send in those questions, and we will address them momentarily. Next slide. And for your information, after the webinar, you'll be able to access a replay of today's webinar, an audio recording, a written transcript, and the presenter's slides. Next slide. I'd like to return to the audience's questions now. Again, please go ahead and submit through the online form. And our first question here, I'm going to direct to you, John, and to LJ. Why were you expecting differences between job positions if all job positions are assessing the same safety culture items in the same working places at the same time? So I think they're curious about why we did this analysis, expecting differences in the responses across the different types of staff positions. John?
I think the best answer is the elephant analogy. That is, people have different views of the elephant, and they see things from different perspectives. Certainly in the offices that I've worked in, I can see differences in attitudes and perspectives between the receptionists, the nurses, and the physicians. So I think it's not surprising that we would see this. Ideally, if there is a lot of open discussion in offices about the specific issues that are measured on the safety culture survey, that over the course of time, people will come to more of a common view. It is a good sign, however, I think, that teamwork was pretty uniformly rated highly in all categories, and I think that's a good start.
LJ, you have anything to add?
Really just to kind of parallel what John is saying, and the physician leadership and managers oftentimes have a little rosier picture and are not as connected to what's going on. They're not sitting in the lunchroom kind of hearing about what the real issues are. And so I think it's a matter of some indication of not having your finger on the pulse. And I think those practices that schedule regular times to sit down and tell stories and reflect on things where there's a more horizontal relationship are going to have better positive scores. There's lots of things to think about here, and we hope to look at that in more detail.
Thank you. Our next question, I think it's again for you, John and LJ, about surveying practices staffed by residents and faculty who see patients on a part-time basis. Would you recommend surveying those residents and faculty?
Yes, I certainly would. Even though they may be there a third of the time or half of the time, I think their opinion is important, so I would include them.
LJ, how about you?
I would agree with that. I think that we're seeing increasing numbers of those types of practices, and this survey is quite valuable for those practices and meaningful.
Thank you. Our next question is, can you talk a little bit about the manpower hours needed to complete the process, the survey, from start to finish, and also about the costs? I don't know if, LJ, you have a sense of this from the 300 medical offices that you helped administer the survey in.
I suspect we did this in 11 networks, and there are probably 11 different responses to this. It does take a fair amount of time, and we had support to do this. Our sense is that it takes some outside facilitation to engage the practices both in administering the survey and being there face-to-face, getting the surveys done. And then in terms of, it's nice to get the results back, but in order to get practices to reflect on those, and if you're working with a set of practices, you actually need to go sit down with them because otherwise it's going to sit in a stack on their desk and not get looked at. And so I think it does take a fair amount. It does take a fair amount of time. I think it's only going to be as much value as the effort and time that you put into it. And I do not have any economic data of saying this is how many dollars it would take and what staff FTE it would take to do that.
John, any experiences from you with Cleveland Clinic?
Clearly, it takes effort. Consider that those who complete the survey spend between 10 and 20 minutes to complete it, so that's their full obligation. The time involved is the one that's doing the administration of the survey. We found when we did it at Cleveland Clinic that having one person responsible in each individual practice was sufficient to get the work done, to pass out the questionnaires and pick them up in a confidential fashion. We use sealed envelopes. And then there are the data entry issues. So if you do it with paper form, then somebody has to enter the data into a database, and AHRQ provides a terrific database that you can use to put the results into, and then the database has macros that will do the analysis. You also will have the option, I believe, and Joanne can answer this, of doing this online. So that's another option. I don't know that that's available yet.
Yeah, John, the Agency for Healthcare Research and Quality doesn't support a sort of central web survey. What was done in the pilot test was that one of the systems actually had very good Internet access in their medical offices, and they administered the survey themselves through the web. So we know that the web is going to be a mode that increasingly medical offices are going to be able to access. But what we found in the pilot was that we had better response rate on paper, and that you still are going to have a little bit of a more difficult time, even in hospitals, getting the response rate that you can get on paper with the web. The paper is still the best way to go for a higher response rate. Next question. Once a survey is administered and results are received, will there be help from AHRQ to address areas of concern? And I can probably answer this question. WESTAT is the support contract for AHRQ to provide assistance to users of the survey. Right now there is a medical office resource list that's on the AHRQ website, and it lists dozens of free online resources that address the various areas that are assessed in the survey. So I recommend that you go to the AHRQ website, to the Medical Office Survey page, and then look at the Medical Office Resource List and check out some of those resources which address things like access and information exchange and follow-up. And I would recommend you start there. And then if you certainly have questions, you can send them to the Safety Culture Surveys mailbox and technical assistance line. The next question, are there identified best practices that are linked to the survey areas? For example, how to address work pressure and pace. John and LJ, I don't know what your experience has been in terms of, once you have the results, what your next steps have been with the medical offices.
Unfortunately, the research is thin in this area. And although some organizations do very well and have developed their own internal best practices, I don't think anybody has published much in the way of best practices. As an example, my research group has been working on best ways to follow up on test results, which is a real safety issue. Our group has also done a little work on ensuring accurate medication lists, another big safety area. But by and large, I would say that safety research in the office setting when it comes to implementation and best practices is still at an early stage, and there is great need for work in that area.
LJ, any comments?
So what we found is we actually had, so I'm going to speak as an individual network, so we were one of the 11 networks, and so we did 36 practices in our network, and so I think there's an opportunity here if there was, again, you have to find some support and funding for this, is we have exemplar practices. I'm looking at work pace and pressure, so the average is like about 44% positive responses, but I had a couple practices that were 80 and 90% that had positive responses, others that had 22% and 15%. And so it would actually take trying to figure out what's going on in those practices, what are the characteristics of those practices that allow them to really do really well or to be more challenged in those areas. And so I think there's plenty of opportunity to look at it, but we're going to have to get down to the macro system level to understand that.
Thank you. Our next question is, since if you have an office with fewer than 10 staff, what do you recommend doing with these offices in terms of breaking out the results? And Naomi, perhaps you can address this in terms of the rules that we use for the comparative database on hospital versus medical office and kind of the differences in the required ends.
Sure. So for medical office, to get results, all you need are 5 respondents, not 10. Hospital, it is the rule of 10. And then for the breakouts of the different staff positions, as long as if you're giving feedback, if you're looking at your own results, we would say don't do anything with less than 3 for confidentiality reasons. For the comparative database, we will include at least, as long as you have 1, we'll include it in the benchmark. Since some of the staff positions, there may be fewer than 3 in a given medical office.
Thank you. Our next question is, do you anticipate that payers or other groups will expect office practices to conduct these surveys as part of recognition, pay for performance, contractual obligations? John or LJ, any thoughts on that?
Yeah, the answer right now is yes, if the practices belong and are certified by the Joint Commission, because the Joint Commission now does require periodic surveys of safety culture. So, for example, Cleveland Clinic just did their most recent survey this past summer, which included not just the hospital employees, but all the offices. In smaller offices, I think no, but I would guess that eventually all accredited practices will need to do some kind of assessment of safety culture on a periodic basis. I don't know if that's once a year, once every 2 years, or what.
You know, this LJ, so to my knowledge, and maybe there are other tools out there, but this is the only tool I'm aware of that really measures the experience of care from the people that actually work in the office. We have patient experience of care tools, and we have clinical measure qualities, but this one actually has people respond to kind of from what are their perceptions of what's going on in these various domains here. I think it's incredibly valuable. I think it's mostly useful internally for practices to start to reflect on how they're doing and to enhance their communications structure. I'm not sure how much payment's going to be attached to this, but I think it's a tremendous tool for practices to engage each other in talking about these various quality and safety domains.
Well, thank you, LJ, John, and Naomi. Before we close, we ask that you please take a minute to complete an evaluation of today's webinar, which will automatically appear on your screen in just a moment. Your feedback is very important to us. We're also providing a technical assistance email address and toll-free number if you have any further questions or comments on the medical office survey. And we've also provided the link to the medical office survey pages on the AHRQ website. I want to thank you again to our a big thank you to our speakers, and we definitely want to thank you all for participating in today's webinar.
This concludes today's teleconference. You may now disconnect your lines at this time, and thank you for your participation.